Hello and welcome to Building Better Health. I'm Terence Samuel. The trope of the burned out doctor is nothing new. And HBO's smash hit, The Pit, about the never-ending crises that make up a day in the life of a Pittsburgh emergency room, has brought it front and center yet again. But contrary to what you see on TV, it's not just ER doctors feeling the pressure. Burnout is at record levels across the board, and medical students are stirring away from primary care in growing numbers. Today, we are talking with two of the nation's leading physicians working to change that trajectory. Dr. Patrick Conway, CEO of Optum at United Health Group, and Dr. Sharmila Makhija, the founding dean and CEO of the Alice L. Walton School of Medicine in Northwest Arkansas. Welcome to both of you.
Thanks.
Thank you.
Dr. Conway, a long and interesting career. Talk a little bit about kind of the stops along the way that got you to this place where you're kind of dealing with this issue head on.
Yeah, so I did not plan it, but out of undergrad, I was going to do Peace Corps, Teach for America, McKinsey Consulting, or direct to medical school. Pretty random four in retrospect, but went to McKinsey Consulting, learned healthcare on the job, went back to medical school, trained in pediatrics at Boston Children's Hospital, did an RWJ clinical scholars program to learn policy and epidemiology, went to Cincinnati Children's to learn quality improvement and system redesign, did a White House fellowship in the Bush administration, then stayed on as chief medical officer at Health and Human Services, really learning policy. Went back to Cincinnati Children's, was going to be a Children's Hospital CEO. That was my goal. Then got called back into government service, was chief medical officer of CMS, Medicare and Medicaid, deputy administrator, acting because I was never political. Then was CEO of Blue Cross North Carolina, ran a health plan in a state, tried to do whole health at a state level. And then I've been at Optum 7 years in different roles, now CEO of Optum. And at Optum, to describe what we do, you've got Optum Health, which is integrated value-based care for people, doctors, nurses, others delivering holistic, integrated value-based care to people. Optum Rx, which is pharmacy. It delivers medications to people, right medicine, right patient, right time, affordably is the goal. And then Optum Insight, which is our data technology business, which makes the system work better using AI. And so if you think about Optum as a whole, it's all about health services to people and how we address and care for them, their physical, mental, pharmacy, and social needs.
So if we're going to solve this, it's on you.
Yes.
It's on us and a lot of others. We have to partner, but we have a lot of work to do together.
Also, a long and varied career, starting at the University of Alabama, Birmingham?
That's right. If I may, I promise I won't go too much in detail, but with starting off, I was born and raised in Montgomery, Alabama, to two teachers. And so quickly we learned having educators in the family. That was very important to me and to our family. And often at the dinner table, which is what I do now when we're sitting at the table with our teams, my parents would often ask, not only what did you learn today, but how did you make someone else's life better today? And I think that is what has pushed me into or driven me into always serving a community. I went to Cornell for undergraduate, came back to UAB, University of Alabama, Birmingham for med school, went to Louisville for my residency in OBGYN, knowing that I wanted to do GYN oncology because of the way we took care of patients as a medical student in oncology. We took care of the whole person. We took care of the family. So that was always ingrained in me early on as an oncologist, this whole person care. We just didn't call it that back then. I went on to do my fellowship at Sloan Kettering in GYN oncology, and then came back, almost repeated every place I've been to. I went to Pittsburgh, Magee Women's for my first job, became a NIH scholar. So I did translational research in ovarian cancer, came back to UAB, was on faculty. Fast forward, I went over to Emory to become the division chief of GYN oncology. 2008 hit, the financial crisis. All the endowments were cut. I came in as a Georgia Cancer Scholar to build up that program and learned that I didn't know the language of finance and business. So I literally walked next door and signed up to do an MBA at Goizueta at Emory and learned that it wasn't just finance. It was organizational behavior that really connected to me. And I think that was the pivotal moment for me as a leader to understand how you work as teams and how do you actually create impact. Went on to Montefiore, Einstein College of Medicine in the Bronx for 8 years, was a department chair of women's health. And then I was happy and enjoying myself in New York, and I got a call to look at this particular position at Alice Walton School of Medicine. And it just connected because it was about whole person care. Alice really wanted the mission to be, how do we look at this whole person? How do we change healthcare? That connected to my upbringing, to all the work I had done to date. And it has been truly a pleasure to work on this curriculum with our teams. We have an incredible team that created a curriculum called ARCHES. So Art of Healing, Research, Clinical, Health System Sciences, Embracing Whole Health, and Sciences. That particular curriculum is what we have implemented. We had our first class that started last year. So within 2 years of me starting there, we had built a school, the building, inaugurated the first class. We are about to welcome our second class, and we've already started recruiting our third class.
Can you talk a little bit, both of you, and I will start with you, Dr. Conway, about where we are in the conversation about physician burnout? It's not new, as we've said, and it has gotten some attention in recent years. Are we in a better place or worse?
I think on burnout, it's a major issue. I think we have pockets of improvement, but we need to make that more broad-based. If I go back, I've now been a practicing pediatrician for 25 years. I was in the era before work hours and actually was featured. I had an accident driving home after working for 36 hours. So in the safety studies that were in Boston at the time, I trained at Boston Children's. I was actually part of those studies. We don't do that anymore. We have more reasonable work hours. I think now our real work that I think we'll talk about today is how do we make the system simpler, better for the physicians and clinicians in the system? How do we enable what they want to do? When people go to medical school or various clinical training programs, they want to help people live healthier lives. They want to, help heal people. It really is a calling. So how do we enable them to deliver on that calling each and every day? The last thing I'll share on a personal level, I got a nephew now in medical school. I have a daughter who thinks she wants to go to medical school.
The family business.
Right. I got 2 siblings that are physicians. It's personal, and in our business at Optum, we support, many thousands of doctors, nurse practitioners, and others across the system, and we're trying to enable them to do their best work.
So burnout can be shown acutely, right on the spot of not being able to handle a bad outcome. But we're seeing long-term effects that they're not staying in the field. So in medical school, and I always said to myself, if I could ever start in medical school to help students understand how to manage the stress, I would do it. And that's what we're doing at the school. We are starting right off the bat with even who we recruit into the school. We look at their background. We look at, are they coming from a rural background that can better understand the people that they're going to serve, the community they're going to serve. And then we've built a curriculum that looks at incorporating it into the curriculum as to their own self well-being. How do they take care of themselves to better take care of others? So we're starting front and center. We're calling it out. We're talking about it. We're keeping this an open dialogue. And we've also built a school that physically empowers them to be out in nature and to help them with recovery while they're studying, because it's a very stressful time. And we're trying to build good habits right off the bat.
When we talk about the crisis in healthcare, American healthcare in particular, it's always about affordability and access and quality of care. How does this particular issue fit into that equation?
So it's essential. So, there's actually evidence on this. If your physician, your clinician, your care team is less burnt out, is more enabled to deliver their best work, it's more affordable, it's higher quality. If you look at the Optum models as just one example, decreased hospitalizations rates, usually 14+%, decreased avoidable ER visits, net promoter scores or satisfaction in the 80s and 90s, access to that care, and physicians and clinicians that are practicing in a value-based care environment and doing their best work. I always like data and stories. The story I'll tell is a geriatrician who told us she was about to just retire in her 50s, and then we let her do home visits, where instead of doing, 15-minute fee-for-service visits, she goes into a elderly person's home and does comprehensive care, usually an hour, sometimes longer, for their physical, mental, social, pharmacy needs. And she loves it. And now she's excited to practice medicine again. And that's what it's all about.
Yeah.
She's a geriatrician retiring in her 50s.
She was going to retire, I know. It's a little ironic, but now she's not. So we hope she practices, for a very long time. And the last stat I'll give, if you look at burnout in Optum physicians in a value-based care environment, it's 34% lower. So 34% lower than average. And I think that's and we still need to improve too, but you're enabling those physicians and clinicians to work as part of a team and deliver care the way they want to.
So our foundation is based off of what we call whole health or whole person care. So we've changed the dialogue from what's the matter with you to what matters to you. So having that open dialogue with the patient, and that's what we're trying to now train students in, understanding the whole picture. The patient is not just the issue they're coming with, but they're a human being that have other issues, other needs, other desires, and talking about that in a more specific way. What's interesting is we are also adding in the fact that there's a delay of learning something in school and then putting it into practice 2 years later in their clinical clerkships. What we've done is accelerated that. So I wanted them to be able to learn the sciences, learn about these strategies of self-care, practice in a simulation setting, and then go straight into a clinical setting. So within 3 months of starting school, they are working with our partners at Mercy Healthcare System that actually practice value-based care. So we wanted them to learn it and apply it in a real-time setting and being around physicians that are already practicing that. And we feel like that has accelerated their connection to understanding how to keep improving and learning.
Look, I want to go back to medical school in this medical school.
Yeah.
So, the ability to train future physicians in a way that is whole health oriented. As a pediatrician, you learn to focus on the family and the whole person, but all doctors and clinicians need to do that.
That's right.
And they're really changing the paradigm of how we train physicians, which is super exciting.
You, in a throwaway line, said you want to go back to medical school. Talk a little bit about what you mean by that. Seriously, you're not going to go, but...
Yeah. Maybe. I'm still learning. Look, I'd say the following. So I actually started working in business before I went to medical school. That actually was helpful because you had interacted in healthcare and sort of learned the business side of it. By the way, I contemplated leaving medical school and I didn't because we had just an hour with a patient in the beginning. So they're doing much more than this.
Right.
But I was like, this will be... Look, I tell people that are thinking about medical school, including my nephew, it is a calling. I still believe that today. It's why I still practice. And I believe our system has made it harder than it should be. And so, I think if you have an interest in caring for people as a clinician, people should do it. And then we, as leaders and organizations, and I've worked in government as well, need to set up the policies, the parameters, the support systems so that clinician can focus on the patient and deliver the best care possible. And so how do you remove administrative complexity? How do you make it similar? Another example, we're using ambient listening and AI to document for clinicians. It's saved over 2 million minutes of clinician time.
That sounds like a lot.
It is a lot. We have a lot of, we have a lot of number of people.
Right.
But that's real time, right? And when you ask patients what they want time with their physician or the clinical care team to be cared for.
What do those clinicians, as a collective, need the most?
As I interact with those folks, and I ask them, okay, you joined Optum, how do you feel about it? They're generally incredibly positive. What they're excited about, to answer your question, is, you removed a lot of the administrative complexity. You got rid of the prior auth and the coding and the various things, so that's handled for me. You have an electronic health record and a system that does my documentation, that does the things that, referrals to specialists and other things. You handle a lot of that for me. If we let's take Kelsey in Houston. That system can care for almost anything a patient needs, and it's all oriented on keeping people out of the hospital healthy. If you need a surgery, can we do it in an ambulatory surgical center? Quicker, faster, better. If you need mental health treatment, do we integrate that? Yes, either virtually or in person. So that when you build that system around clinicians, it's very positive. Now I practice in a safety net hospital in Boston, Boston Medical Center. That is, you see the failures of the system. So the kids that get hospitalized on a given weekend, it'll be mental and behavioral health where they didn't get care, adolescent. It'll be a baby born to a mom who was on opioids because our substance use treatment and prevention systems didn't work. It'll be a child with multiple chronic conditions and we couldn't deliver home care on a weekend, so we hospitalized the child. A value-based care system can prevent those kind of things and keep people healthy and out of the hospital. When I ask families, and then I'll stop, what they want after they get hospitalized, the most common answer is I want to get home as soon as possible and I want to stay home as long as possible with my child. So how do we provide a system that does that?
One of the areas that a lot of the physicians have frustrations with or burnout is that there's a loss of control. Things happen to them. And I think it's our own fault. We say we're just here to take care of the patients and we're committed to that. But when there are new technologies or new things that are happening, somebody else is deciding how we should apply that. So we have a particular area in the curriculum called Health System Sciences where we're teaching them about the infrastructure, the policy that Patrick talked about. How do you impact healthcare in different ways?
So every discussion about how we fix this starts with primary care. And then you're telling us today that a huge problem with primary care delivery is that the clinicians best positioned to do it are overworked, overburdened. How do we get there?
Oh, that's an easy question to answer. I think it's multifactorial. So one of the primary drivers, and let's just call it out, is the what do we pay for? Because that does drive behavior. And, I'm an OBGYN, I'm an oncologist by training, but we are primary care. And I do think primary care is the hardest area to work in because you are taking in every problem and then you've got to decide, can you take care of them or can that be moved on to a specialist? They have the hardest job and yet we reimburse them the lowest. So that modeling has to be looked at. And it's not that they are doing it for money, but you have to balance the equation. It has to have some more value to that. So I think that's a big part of it. I do feel that the access issue, because there's not enough primary care doctors, especially in rural America, which is what we are very focused on at the school and with Alice's other visionary goals. How do you provide better access that may actually reduce some of the burnout that we're seeing? So virtual care is not something new. It was heightened during the pandemic, but really utilizing that to not only give access for patients, but to provide support for those primary care physicians that are out in rural America so that they can access the specialists without having to send patients or feel like they've got to do extra work. That is another way of looking at how do we support this.
Primary care physicians and clinicians in our system are incredibly valued because they are the workforce directly partnering with the patient populations and managing that patient population, including the patient not in front of you. So a lot of our work is, this is hard as a physician. Okay, I'm caring for a bunch of people with diabetes. How do I find the patients that didn't come in? How do I get them in, either virtually or in person? How do I close those care gaps so they get better health outcomes? That is, dual eligible patients, where we take risk on more than 1 million dual eligible patients. These are people on Medicare and Medicaid, so elderly, disabled, poor, or all three. And we care for them and we'll go to their homes. And I've been on visits where you see a 91-year-old in her home, used to be hospitalized more than 10 times a year before, 14 chronic conditions, now 0 hospitalizations. We've addressed her physical needs, her social needs, things like home modifications or food, her mental health needs, real patient story, where she had depression that needed to be treated. And when you do that, it's better for the patient. And it's actually better for the system, and the clinician in that care environment feels valued and they're able to deliver the care that they want to. We are lowering the total cost of care because you decrease hospitalizations, you decrease ER visits, you manage medical, especially medicine spend in a way that's beneficial to the patient. So for us, that's what integrated value-based care is. So it's primary care, specialty care, ambulatory surgical care, home health, hospice. We do all this, mental and behavioral, all wrapped around the patient.
Yes. I would add that we're actually now teaching students what that means and teaching that in the curriculum, because there's that disconnect, right, of expecting that better outcome-focused care, but we aren't training anybody to really look at that. If you're fortunate enough to work for Patrick or for certain healthcare systems that are focused on that, then you start to learn it afterwards. But we want to start up front with teaching that in the medical school, and that's what we're doing.
What would you say to the average person about the state of American healthcare? I mean, we're sitting here because we come to this at some level because there is a crisis. But you seem fairly optimistic about the direction in which we're headed.
Yeah, no, I am optimistic, almost by nature, because you got to keep improving. We have amazing high-end care. That's the envy of the world. But here's the problem. We also have population health and prevention and whole health that people fall through the gaps every day, whether it's not getting mental health care or not getting preventive care or not getting, and that's where I say integrated value-based care and aligning incentives. That's where if you can, and we have pockets of that being successful at Optum and in other systems, but it should be true for all Americans. And by the way, someday everyone in the world, but actually true story. I did international health to start and I was like, I can't fix everything in Nicaragua. True story. As I'm walking around
selling yourself short.
And so I said, but United, U.S. healthcare, there's enough money and resources.
Right.
I should be able to fix that. I was like 23 and didn't know any. It's harder than I thought, but I think we've got, we're making progress, and I think more opportunity going forward.
I think it's really a wonderful time right now to be in healthcare. I mean, there's opportunities. When there's a problem or a conflict, that means there's an opportunity to do better.
The other, you start with the pit. There's a moment in the pit. I used to work as an ER and ICU attending, don't anymore.
Yes.
There's a moment in the pit where the medical student basically says, my shift is over and I'm checking out. Mm-hmm. And now there's a big debate actually among physicians and clinicians online about this. Is that okay? Is it not okay?
That's right.
Look, the culture is changing. When I was in training, I bet it was the same.
That's right.
It was like a badge of honor to stay up and work 36 hours straight every third night. That is not good for your body. It's not good for patient care. So I think the culture is shifting now. Now, how do we keep shifting that culture? So we don't have physicians spending hours and hours at night documenting their day. We don't have physicians who, have to work the specialist referral by phone and fax. Actually, I have to share a story because it's hilarious. I have medical students and residents where I work. And I had this medical student the other day and I'm like, you got to fax that. And he's like, FACTS? And I'm like, no, fax, like FAX. And he's like, what? And I'm like, no, like and I walk him to the fax machine and he's like, what is this? And I'm like, son, it is a fax machine. Welcome to American healthcare. This is used a lot. And actually, you can look into this. The entire fax industry is supported by U.S. healthcare. We are like over 90% of the faxes in the world.
Yes.
Now, take it back to Optum. With Optum Insight, and there's a bunch of people working on this, but we're working on Optum and Optum Insight, how to use Optum Real and various technologies where you settle everything in real time on, using AI and technology. So you, in fact, do not fax back and forth. So there should be a day, and CMS and the federal government agrees with this too, where there are no faxes in healthcare because we have an electronic system like other parts of our lives that is real time, settled. I can see you smiling, but this is true. This is how U.S. healthcare still works. And you had to teach, and I mean, he's like, this is crazy. You dial the buttons? And I'm like, you do. He's like, why is it on your phone? I'm like, great question. So, we have a real opportunity to continue to improve the system, and that's what we're working on at Optum. The pharmacy example I'll give, we actually did this in Optum Rx, and you had average time approval about 8 hours, sometimes days or weeks. We got it to less than 30 seconds using technology. And if there was one more piece of information needed from the prescriber, it would tell them. That's a much better system for the physician or clinician in the system.
That's right.
You said it is no longer a badge of honor to work 36 hours every 3 days. What is the badge of honor for? What this new generation, what are they focused on proving to the world?
They really want to work and help a community that they serve. And what we're seeing, we actually do integrate them into the community their first week of orientation. And that has been the most popular part of their education, is that they're really working with community programs, with the community, and understanding what their needs are. And we're reconnecting them back. And, to Patrick's point of talking about what was good in the past and how it's evolved, I will say one thing we are going back, being a little bit more retro, is the humanities, bringing back the human part of medicine, which sounds like we should be doing that already, but we're not great at that. And so even as we learn and work with technology, we are very careful to make sure that we are centered around the human. And even our art of healing part of our curriculum, because we're sitting on the campus of a world-class museum, Crystal Bridges, we use those educators to teach about art in the school. And that's bringing them back into improving empathy skills, listening skills, visual skills. And that is helping them become better people. That is what the feedback I'm getting from students is their families are saying, wow, I thought you would be a little bit more into just study, and you're actually noticing things and you're talking about things. And so to me, I think that's already a success. That's what we want to see more of. And because it can't be all or nothing. It really should be a balance of all of that. And I think that will be a better way of producing these leaders in healthcare.
You just need better humans?
Better humans.
Dr. Conway?
Yeah, look, both in my clinical role and in the Optum role, we have to make sure that that's the focus. You have a person and a family in front of you, then you have to care for the whole person. One more clinical example, a single mother, 15-year-old mother, who moved states, didn't have WIC in the state, which is what provides bought like an energy drink and gave it to her baby because she didn't know better. The baby actually had a seizure. The baby's doing better now. And the resident was about to just discharge her. And I'm like, do you know where she's going to sleep tonight? No.
Yeah.
Do you know how she's going to get WIC in this state? No. So how's she going to get formula and sleep? Well, you delay the discharge, which is the appropriate thing. You get the right system set up for her, and that's a teaching moment for that resident. Now, hopefully, if they went to the Walton School of Medicine, they would have learned that before residency.
Right.
And very well-meaning, right? Mm-hmm. Well-meaning, right? Mm-hmm. Like the clinicians in the system are always well-meaning, but how do you teach them and build a system that's based on the individual and family in front of them and the population they serve in the community they serve?
Let's end on this. You just talked about an amazing physician dealing with a very difficult patient situation. How does the physician heal himself or herself?
Look, I'm glad you in on this one. We do need to focus on physician and clinician whole health, including their mental and behavioral health, et cetera. It's very important to me personally and our organization. When I do town halls and various things, I often say it's okay to not be okay. And if so, please get the support you need, and we have resources for that. And it's a critically important issue. So mental health, suicide, et cetera, is actually higher in the physician population than the general population. And the stigma around it, unfortunately, is still real. And so I think we have, once again, I think we're improving, but I think that aspect of the care we do to the physicians and clinicians, I think we need to continue to improve.
I couldn't agree more. The stigma is, I think, the problem. We're making it more available to talk about. We're making it easier to talk about, trying to destigmatize that. I think that our community leaders, the physicians in the community that are now serving as mentors for our physicians and our students, are talking about it more openly. So we have an entire faculty development group that's helping those community doctors learn how to talk about it so they can support our students. But it's actually been very beneficial for them. So I think creating that community of support, and I think that makes it easier to deal with and know that you're not going to be labeled or shunned if you are having issues. That's a start. I mean, we're just starting that, but we're seeing that impact already. And I think the more we can be open about it, I think the better off communities are, because we will support each other instead of just labeling each other.
Well, we're out of time, but not burned out at all. Thank you so much for an amazing conversation. And we'll keep talking.
Thank you.
Thank you.